we have a meeting prior to our clinic for an hour where we discuss the people we're going to be seeing in the clinic, and we discuss people in the community or in hospital who are in trouble. And it might be about secretion management, so difficulty about secretion management. What have we done? What's worked? What hasn't worked? What are we going to do next? It might be about any other particular problem where having a multidisciplinary team present with different expertise. And the thing about this is that everybody who's in our team is invested in providing the best care possible they can, and the patients feel that. They see the commitment, and you can see the commitment from Brooke, that the patients know whether you're expert enough or not. And if you're not expert enough or not, they know that. And if you're not, then collaboration is the key, as Brooke said, that one should then try and find out who else is part of that team, and then perhaps give them a call, ask if you don't know. Don't say, I don't know what to do. What you say is, I don't know, and I'm going to try and find out what to do about it. And as Brooke said, we're constantly amazed about the lack of communication that happens within our health system. And particularly, we've had people going to hospital being admitted under medical teams in Charles Gardner, for instance, where we know them, we know their family for the past 3 years. They go in with a bout of pneumonia or whatever, we're not even informed that they're there, either from the family or from the medical team. It's unbelievable, it's ridiculous. But when we do know, then one of us will go and see them, or we'll communicate with the team and help out and whatever. So don't be afraid to look into the blue book, look into who the team is. Don't know, then ask, and we will try and help out. And how we cope with, I mean, I've known a lot of people with motor neurone disease over that last 40 years, and I've seen a lot of people die. And how do we cope with that? We cope with it by being part of a team and being able to talk to one another and dealing with any problems that arise through communicating with each other. In any event, I'm now going to talk a bit more about secretion management, because it's one of the worst symptoms of motor neurone disease is if one loses cough and then one begins to get build-up of secretions and difficulty clearing them. It's one of the worst symptoms of MND, and we've learnt as a team, as Brooke has outlined, ways in which we can manage it most of the time if we pay attention in detail to what's going on. I'm going to look a little bit about dysphagia and PEG rig gastrostomy, the role of exercise, cognitive behavioural problems, pain in MND, continence problems, communication enhancement, and then formal palliative care role in MND. One of the references that I've given you is this one. So this is an article written in the Medical Journal of Australia in May 2017. So if you can get access to this, then you should, because it's a very good summary article of where we're up to in all aspects of MND. And the people who wrote it, so Merilee Needham contributed, but Paul Talman from Victoria, who runs the Motor Neurone Disease Registry and very big experience in MND, Rob Henderson in Brisbane, MND neurologist and multidisciplinary clinic, Richard McDonnell and Susan Mathers in Melbourne, David Schultz in Adelaide, Margie Zong's the nurse, as part of one of the multidisciplinary teams in Sydney. Steve Vusik's a neurologist in Sydney involved in MND care. Professor Keenan, huge figure in neurology in Australia and in MND, who's committed to MND because his mum had MND. And he's a brilliant researcher, a brilliant clinician, head of the Australian and New Zealand Association of Neurologists. We're now ANZAN as opposed to ANZACs, with the Australian and New Zealand Association of Neurologists, because we realised we had so much in common with our New Zealand colleagues, and in fact most of the specialties, or all of the Australian physician specialties are linked to New Zealand now. We're joint colleagues. As part of this article, there is a table that outlines just a summary of symptomatic treatments for motor neuron disease. And in one of them, one of the aspects of this is management of excess saliva and secretions, thick and thin, and some suggestions. And I'm just going to take that a little bit further today as to some of the things that we have found out about this. There was a survey done of the multidisciplinary clinics in the UK a couple of years ago, 2 years ago, about how they manage secretions and documenting on their patient load as to who was having problems with secretion and what they actually did, what medications they did, what non-medication things they did. And they found that, and we would find that up to 50% of people with MND have worrisome drooling or thick secretions and have a major impact on quality of life with social isolation or aspiration risk. It can be difficult to control, particularly if there's a mixture of both thin and thick, but especially if there's very thick secretions. We make 500 to 1,500 mils of saliva a day, and it's this the problem of the poor swallow and cough that results in the accumulation of secretions in the throat and the back and the upper airways. Sometimes the problem is so severe that we just can't get on top of it with some of the things that we will try, as I'll show in a moment, and that we have to admit patients to hospital to try and get control of the situation, particularly with mucus plugging and recurrent admissions with respiratory failure and difficulty with breathing. We quite often see people come in using a face towel or tissue, and it's embarrassing and can cause excoriation around the mouth. And if it's thin secretions and it's a relatively mild problem, particularly at night, then the use of tricyclic antidepressant medications in low dosage, such as amitriptyline 10 to 25 milligrams at night or to 50 milligrams at night, or imipramine, can often give quite good relief during the night or into the morning, and sometimes used 3 times a day may be sufficient to just dry up those thin secretions and to give good relief. Strangely, an antihypertensive medication called clonidine in low dosage can also act as a drying agent. So these would be some of the first things one would try if it's just a thin secretion problem. In the UK, they use the hyoscine scopolamine or hyoscine patches, which we don't have access to, but we do have hyoscine in Donatabs, which is an over-the-counter medication, and where Donatabs, again, is an anticholinergic drug blocking some of the nerve endings to salivary glands, can be helpful, and as an alternative or as an adjunct to the other medication, or buscopan or propanthyline. So these are the usual first-line drugs that we will use for thin secretions if they are a problem for the person. Sometimes people would prefer to just put up with it and just use a towel or a tissue because they don't want to run the risk of side effects from these medications and it's not troubling them sufficiently. But if it is, then this is where we may start the process of looking at those thin secretions. Another thing that we use is atropine eye drops, where 1% eye drops, where 2 to 3 drops sublingually, so placed in certain areas just under the lips, as required up to 3 times a day, or diluted in 100 mils of water as a mouth rinse up to 3 times a day, can dry out the salivary glands around the mouth and give some relief. One has to be a bit cautious about this because if you can overdose, and there can be problems with pupillary dilatation, with confusion, other side effects coming from absorption of atropine eye drops if it's used too liberally. But in some people, this works nicely. It can be quite bitter, and people will sometimes take a peppermint with it to cope with that. The revelation to us was when we began to use glycopyrrolate subcutaneous injections for people with severe and frequent excessive saliva. Where this is used off-label, it's used in the ICU to control secretions, but it's not traditionally used long-term over months to years as a way of controlling excessive secretions. It's an anticholinergic drug which can be given orally or intramuscularly or subcutaneously or intravenously. But we've found that subcutaneous injections, and I'll get onto the detail of that in a minute, can be absolutely life-transforming for some people, where it always works within 15 to 20 minutes and will last up to 3 to 4 hours or 5 hours. And where strategically used at night, for instance, or before a social occasion, or regularly, can really give good relief for people with minimal side effects usually. There's Botox, botulinum toxin injection into salivary glands is an option, and I'll talk about that. And I've done that in a number of patients with some success, in others and no success at all. And the electric home suction pump may be helpful at times, still in thin secretion management. The suction pump for mouth suction fell into disrepute where it was considered a no-no because if one's stimulating the salivary glands, it just makes more saliva. But we've found that, in fact, it's been very helpful and as an adjunct to other things that we're doing, and we've brought it back into popularity and use. The glycopyrrolate medication is helpful because it's an anticholinergic drug which does not cross the blood-brain barrier, so that within the arteries and arterioles and capillaries in the brain, there is a thing called a blood-brain barrier which prevents entry of certain medications into the brain as opposed to other organs. And so the fact that it has little penetration to the brain is helpful in terms of reducing side effects. And it comes as a 200 microgram ampoule. And when we use it, we started off at a small dose of 50 microgram test dose and see what effect it has, and then we increase increments every few days to a week depending on its response, the person's response, up to 1 to 3 times daily, or use socially PRN or at night. And most often we need to get up to 100 to 200 micrograms each dose to get the appropriate response, and can be drawn up out of the ampoule and kept in an insulin syringe in the fridge. So you use up all of the medication by putting it and reserving it in the syringes, in the insulin syringes. And we can teach some people to give it themselves if their hands are capable of doing so and they're capable of doing injections themselves, or a competent carer or a nurse in other situations may deliver it. And certainly when we start it, it's started under a protocol that's been developed by the Neurological Council WA nurses, who will run through this particular protocol and liaise with us depending on the responsiveness of the patient. I'll talk about how we get hold of the medication in a moment, but these anticholinergic drugs can have side effects. So excessive dryness of the mouth, constipation can slow the bowel down, can change taste, can give nausea, and I've had one man who had a long-term who developed impotence as a complaint about the effects of the drug. Urinary hesitancy, blurred vision due to dilatation of the pupil, and sometimes drowsiness, dizziness, but because it doesn't get into the nervous system very much most of the time, that's not a problem. Occasionally people have injection site reactions to it and can't tolerate it, but that's very rare. I've never had anyone with a severe anaphylactic reaction. Had some people where they've had reduced sweating and overheating. But most of the time it's been a remarkably benign drug in our hands. So it's very expensive. You can't really afford it outside of getting it through a public hospital prescription. And so we've got a deal with our pharmacy, as do the other clinics, to provide it. from hospital outpatient for a minimum charge. And so we usually prescribe it, and they'll give a month and 3 months and 2 repeats to get 3 months supply. We quite often have to provide for palliative care patients as well, although some palliative care consultants will provide it, and particularly in the country they can do prescriptions. And we ask the patients to get the insulin syringes from the chemist. When you see writing about control of liquid secretions, you quite often see about, well, Botox is the way to go. You know, everyone loves Botox for everything these days. And it can be great taking wrinkles out of the bladder. You know, so if you've got a hyperactive bladder with multiple sclerosis, for instance, injections into the bladder up to 9 months will slow things down very nicely. I did have some left over after one Botox clinic, and my wife's got a couple of wrinkles and said, "Why don't you give it a try?" And I did, but it didn't work. You know, that was the only time I did that. But you know, but the thing about the nurses who attend these clinics, they never get older. But you'd think, well, you know, botulinum toxin will block the nerve endings into the salivary gland, reduce the degree of salivation, and the acetylcholine receptors will regrow, and so it's a temporary relief which will last 6 to 9 weeks or so before the nerves regrow and the saliva starts producing, where you have to then give it another injection to keep it under control. And when I was working at Shenton Park, I did have a rehabilitation hospital. I did have access to the radiology department and ultrasound there, where we would draw up the botulinum toxin in a syringe. We'd take it along. The ultrasonographer would identify the parotid gland that sits in front of the ear here, which provides most of our salivary output, particularly in response to food. And we'd identify the submandibular gland underneath here on ultrasound, and then I'd hand him the syringe and the needle, and you can see the needle tip directly in the gland. You see it wiggle around. You knew exactly where you were. Could avoid the facial nerve, which goes through the parotid gland. And we knew we were actually in the gland itself, and we would give 2 injections. He would give the injections there and there into the gland. And we knew, and we would use doses that related to studies that have investigated this, but it was very hit and miss. Some people got good responses, some people disappointingly had very little response at all. And I've subsequently done in a number of other people with landmarks where you can do it without ultrasound, and you just, there are particular landmarks that one can identify to just inject blind into these glands. And where it remains an option, but it's not a reliable way of treating hypersalivation. And again, there's a bit of a worry that there can be a spread of the Botox into the swallowing muscles and create increased dysphagia. So it's not a great solution necessarily, but for some people it may be a useful adjunct. Thick secretions are the worst, and what we've found is that people who have dysphagia and excessive secretions quite often don't hydrate sufficiently, and we've found that, as Brooke indicated, that we really must keep up fluid intake to try and loosen up some of those secretions. And there's one trick I saw with one of our patients that the palliative care people at Charles Gardner used, where they use subcutaneous infusion of fluid when we're having a big problem with a particular person, where again, once we got enough fluid into him, and in the hospital and at home, by the use of subcutaneous fluids at times, it helped the secretion management. People talk about natural mucolytics with granited fresh pineapple and dark grape juices, which have enzymes which can get into the back of the throat and help loosen up the juices. I must admit I've never had any great success or heard of anyone with any great success with that, but maybe some people do get help. Over-the-counter medication, Bisolven, Chesty Forte as a mucolytic or bromohexine. And so again, we quite often prescribe this if there are thick secretions as a background, but again, there can be side effects from this medication. Regular saline nebs with or without N-acetylcysteine and a cough assist machine for the more severe cases is where we quite often end up. And in some people, we're now getting help from the respiratory physiotherapists, and we actually know how to teach this as well, but teaching manual assist coughing with breath stacking and the use of a cough assist machine have been very helpful in controlling the more severe cases. N-acetylcysteine, again, a medication which we have to prescribe from our pharmacy, and there's a particular way in which we use this, and where it can give bronchoconstriction, and where we have to use salbutamol before each particular nebulizer with N-acetylcysteine, breaking up secretion, often followed by the cough assist machine. And so this has been a very great learning exercise for us in the last few years about how to cope with excessive secretion, particularly the thick secretions where it's not well written up in the literature, and where the multidisciplinary team management with speech therapists, with respiratory physician, respiratory nurse and a doctor monitoring what's going on and feedback from the patient, we can quite often get control of the situation. I'm not really going to say anything much about dysphagia. Perhaps a little bit about, when you hear about people with bulbar or pseudobulbar palsy, again, these are sort of anatomical, neurological descriptions about the bulb of the medulla and the pons of the brain stem, where the major pathology might be lower motor neurone to the tongue and throat muscles, causing trouble with speech and swallowing. Pseudobulbar, where it's predominantly upper motor neuron inputs to the tongue and throat muscles, which is causing the problem rather than the lower motor neuron thing. So you might say, oh, you've got a pseudobulbar palsy, is an anatomical clinical expression related to the relative contribution of lower motor neuron, upper motor neuron. So dysphagia often leads to poor nutritional status, dehydration, weight loss, and can affect risk of aspiration and cause coughing, and prolonged eating time lead to social isolation. And we're very dependent on speech pathologists working with dietitian to give advice on swallow techniques, foodstuffs, thickened fluids and supplements. And once this is recognised, it's a matter of monitoring and beginning to discuss with the patient that they may be heading towards a decision as to whether they will take a feeding tube or not. Although it's amazing what people will continue to eat. I mean, I've known people to eat hamburgers and all sorts of stuff, and you look in the back of their throat and their tongue's hardly moving, there's hardly any soft palate moving. You think, how do you do that? And, it's just through addiction, I suppose, or, they're just, but it's amazing how they will cope sometimes, where you think, I just don't understand how you're doing this. But they do, and that's fine, Although it can be a problem in nursing home situations where, again, they have rules about if you've got severe dysphagia, you're not allowed to have certain foodstuffs, and the patients say, to hell with that, I'd rather die than miss out on that particular asparagus or whatever. And so then we've said to the nursing home managers, well, all right, can we draw up a contract where you're excluded from responsibility, so that the patient admits that they're putting themselves at risk, and that they might obstruct or have a problem with aspiration, and that could provide a complication, but they're willing to run that risk, and they absolve the nursing home of risk. And that seems to have worked. Have you had that situation? Yeah. So PEG, the percutaneous endoscopic gastrostomy, is the feeding option of choice, and where again, if the person is losing weight, is taking prolonged periods of time to eat, is coughing, is distressed, and where they're in reasonable shape elsewhere, where they want to go on and be in best shape possible, then we explain the option of a feeding tube, and that the earlier it's done, the better, because the procedure requires you to be able to lie flat for up to 30 minutes or so. So you've got to have enough respiratory reserve. And so we get worried if the respiratory reserve in forced vital capacity measurements is getting around to less than 50% of predicted, because then you're likely to run into trouble with lying flat and be able to tolerate the procedure. And I've noticed that when people have been referred to us from the UK, for instance, with MND, that they get into PEGs very early in the piece, much more than we do. But people are somewhat frightened about, having a tube under their left subcostal margin, about body image, about what it's all going to mean, the complications from it. But fortunately, there's a very good website that I'm going to show you that we use to help explain this to people. And we explain it usually and talk to them usually over a period of time. So it's not just one interview, but getting them used to the idea. And where if they're not getting enough nutrition, then the body will take it out of the muscles and elsewhere. So they're more likely to deteriorate quicker if they're not getting sufficient nutrition. And to explain that it's not either or. So if you've got a tube in, you can take oral intake as to whatever you feel you can take safely. And some people have put a tube in and they've insisted on keeping in oral intake, and they'll only use the tube for fluids to a certain extent, and not for other nutritional supplements until they really need to. But it's really a quality of life issue. And does it lengthen length of life? And you say, well, I don't want to just have a tube where I'll just be lying around being tube fed and I'm going to live forever and I might have to go to court to get it removed or something. No, that's not the case. It's a quality of life issue where the prognostic thing for motor neurone disease is respiratory muscle weakness. So sure, if you present with a bulbar pseudobulbar palsy as a major presentation with minimal limb weakness, or none at all, and you're at risk of aspirating, it's very likely it's going to prolong your life if you have a PEG early. So it can prolong life, and you can, with any of these aids, refuse them at any time. So you don't have to go to court or anything. So if you're tube fed and you say, I've had enough of this, I'm out of here, then you can say, I don't want any more tube feeding, thank you very much. So clamp it off or remove it, and it will seal up, and that's the end of it. Right? So it's not. So again, we explain that it's not either or. You can use both, oral intake and supplements, and it can be ceased at any time. You are in control of what happens. And so, patient comes into hospital, and we over a 3 to 5 day inpatient period. They have intensive training in the use of the PEG. Now, I'm not sure what a PEG flout is. We have regular review and replacement as necessary. If the person has poor respiratory reserve and can't lie flat, then a radiologic inserted gastrostomy through interventional neuroradiology is the option we pursue. It's a smaller tube, more problems with it than the larger bore tube from the PEG, so we try and avoid that if possible. Problem is, a lot of people delay in their decision for having a PEG, and then they end up with a rig. This is the website, an award-winning website, MyTube. Anything you ever wanted to know about PEGs and rigs. So it comes from Sheffield in the UK, and it has a lot of interviews with people and their family about their attitude to PEGs and how they didn't want it, but then when they did have it, they felt so much better, and better nutrition made them feel a lot better and stronger, etc., and their fears were reduced. And so it's a very good website which reduces some of the anxiety about PEGs, and well worth looking up and looking at it yourself to think, yes, well, if I need to talk to someone about this, then I can supplement this with a very well documented and useful website. So here's a happy patient doing his own feeds here. And again, where the patient's instructed in tube care and need to turn the tube each day, and the care about the stoma, and it's again interesting what people get up to in terms of how they manage this individually. Now, role of exercise, people say, well, what exercise can I do?
and whether exercise is harmful or what exercise is permitted, how much exercise, people quite often ask this. So we always say, well, exercise, continue exercise, whatever you want to do, whatever you can manage without pain or without overstretching joints around joints which have weak muscles, or where you're putting yourself at risk. And so I've had people who've been swimmers, for instance, where every problem they've ever had in their life, they've just swum it out. Where you can do too much, right? Someone who did too much swimming because of a weak shoulder ended up with a very painful shoulder. So you've got to watch out for excess of exercise to a point where pain starts occurring or some reaction occurs. Had others who've really, many people have joined gyms and then had supervised exercise at the gym by someone who understands their biomechanics, and where they can make sure that any weights that are being used are in low weight with more repetitions rather than very heavy weights. And so exercise as much as one can within the limits of weakness and safety and without pain and overstretching joints. In some people, they believe that when they've picked up their regular exercise that it slows the disease. They believe it slows the disease down, but and whether that helps regenerate the battle going on between dying motor neurons and other motor neurons sending sprouts to muscle to capture denervated muscle to maintain strength, whether it's helpful or not, it may well be in some people. So certainly stretching, maintaining muscle length, if one has weak hands and the hands are sitting like that most of the time without stretching, then contractures can develop. So regular stretching around weak joints, taught by the person themselves, stretching out their fingers, or by a family member without formal physiotherapy is an appropriate thing. Some patients have got on to things like pedal exerciser, which you can buy quite cheaply. There are even cheaper ones than this one, or exercise bikes. So there are other machines that people can use in the presence of disability to maintain exercise of weak joints and muscles. So it's helpful. We do have a physiotherapist that works with us, Jesse, and he talks to people about their exercise program if they wish to. So we want to avoid excessive fatigue, injury and pain. It can involve walking, swimming, cycling, light weights. Massage, some people have regular massage, which is they like and helps. And there's a need to sort of monitor the intensity, duration and frequency of this over time and in a sort of informal way. And people do generally adapt their exercise depending on what they're able to do over time. And it's considered to be helpful and not detrimental. As I said previously, we've begun to understand that motor neuron disease is often part of within a spectrum of neurodegenerative diseases. And we're aware that particularly with the C9orf gene, the most common form of genetic motor neuron disease, that there is a spectrum within families where one family member may have full-blown frontotemporal dementia and no motor neuron disease, whereas another family member may have motor neuron disease with the motor component but no cognitive deficit, and the whole variation in between. And so that cognitive impairment is usually in frontal and temporal function, different from Alzheimer's disease, where we'll look at the major impacts of that in a moment, and where an awareness that something's not right usually comes from behavioural change or by change in language, and where this is reported by a family member or that you get a feel for it when talking to the patient. And there are screening instruments, MOC or ACE3 or the Edinburgh Cognitive Screen. These are like more sophisticated mini mental state exams that we can apply to actually detect and then monitor if the person will participate beyond what we're learning from the history and interaction with the patient. So when these screens are applied, we find that there is 5 to 10% with moderate to severe frontotemporal dementia, which is pretty obvious to everybody, and about 40 to 50% of people with MND within those community clinics, if you put them under these sort of tests, will perform outside of the norms, that there is quite often an impairment of cognition. And the person may present with frontotemporal dementia, then develop weakness, or the other way around. And it's important to recognise, because these people quite often lack insight, it makes it difficult to interact with the multidisciplinary team. And there has to be early discussion of power of attorney, of medical guardianship, and what that patient wishes longer term, the Advanced Health Directive. Because if you leave it too long, they may not be able to participate in decision making. And the pathology of this we can see. So if there's overt frontotemporal dementia, then one sees in the MRI scan, which we got in 1989 in Perth. We got our first CT scan in 1976. I do go back a long way. And first MRI scan in 1980, which blew us away. Imagine seeing that for the first time. Cross-section, spinal cord, medulla, pons, cerebral cortex, nose, looking into the brain for the first time with magnetic resonance scanning related to magnetic properties of water in the brain. Unbelievable, which allowed us to detect brain tumours, stroke, multiple sclerosis, all sorts of things, but not MND, except if there's severe frontotemporal dementia. So here we have loss of brain tissue compared to normal, big ventricles, fluid taking up the space, lost by the loss of brain tissue, and where there's relative preservation of the posterior aspects of the brain here. And pathologically, again, we can see the loss of the big sulci here and loss of brain tissue in the frontal and temporal lobes of the brain. Most often presents as behavioural variant frontotemporal dementia. So disinhibition, impulsive behaviour, sometimes the opposite, sometimes apathy. Lack of insight, which leads to poor decision making. A loss of empathy. So again, people just become flat. They're much less appropriately emotional and in their relationships. There may be changed sleep patterns, changed eating habits, decreasing speech in another form of this, a less common form of semantic variant where they lose words of meaning, and there's a relative sparing of memory. And this can create all sorts of problems, particularly with regard to the lack of insight and cooperation and the change in behaviour in interpersonal relationships. So it's incredible stress on carers, great difficulty in terms of decision making with regard to PEGs and other interventions, and taking their driving licence away. That's the worst. So symptom management is often difficult. Now, there are fantastic websites that help. So Behaviour Management Guide to Good Practice, Managing Behavioural and Psychological Symptoms of Dementia, but particularly frontotemporal dementia, how to deal with aggression, agitation, disinhibited behaviours, nocturnal disruption, wandering. So this Dementia Behaviour Management Advisory Group has this on a website, as does the Australian Frontotemporal Association website. So in terms of saying, well, where do we get some sort of direction to give to the family? And I take extracts of this sometimes and send it to the carer by email and say, look, if they've got this particular behaviour, why don't you try this? Now, some people are very successful because they've had very good relationship previously, and they get the person into a routine of walking the dogs night and morning. They run the Friday barbecue. They're allowed to have a role within the family, which is very important, which continues something from before, but doesn't require a lot of intellectual activity to do. That's why men are very good at barbecues, and we can focus on one thing at a time. If the marital relationship's been very poor beforehand, you can imagine the stress and the strife that this causes and the disruption to family life and the failure of the relationship quite often. So in any event, and then involvement of psychiatrists quite often helps too. So I don't have there. So psychiatric referral. So sometimes SSRI medications will help calm the patient, not drug them out, but just calm some of the behaviours. And so neuropsychiatrists or psychiatrists with an interest in this sort of thing can be helpful, and we use those psychiatrists as well. one of the things that one sees in patients quite often is emotional lability, a lower threshold for laughing or crying, and again used to be referred to medically as a pseudo-bulbar affect. So this whole thing again about an anatomical term, upper motor neuron effect on emotional expression. So this is the reverse of Parkinson's disease, where Parkinson's disease people have a flat face, they get around and people say cheer up and they go, oh, I'm fine, you know, because you're not smiling, you're not expressing yourself. So we have you know, our brains express our emotions through our faces, and in Parkinson's disease there's the mask-like face. In this situation there is a disconnect between how the person feels emotionally and how it will be expressed physically. So a person may laugh inappropriately or cry, you know, at the drop of a hat, or cry at any minor thing which is totally out of character, and they know it. They say, why am I doing this? You know, this is weird. It may be part of the presenting syndrome for them to do that. In fact, I had a patient with MS who had this, who was at the Quad Centre at one stage, who was there, where every time he spoke, he laughed. He couldn't speak because he just laughed. And he said, you know, why am I doing this? And again, it's part of his pathology, and it just interfered tremendously with social communication, and it was just awful. But once people know what it's about, particularly in the family, then they can deal with it. And where antidepressants of various types, particularly SSRIs, quite often will help dampen it down. But once people know about it and are sensitive to why it's happening and don't get confused by it, then it can be helpful. Surprisingly, depression is not all that common that we see, and maybe we're not detecting it sufficiently. It certainly can be part of carer stress, there's no doubt about that. Hopelessness and concerns about dying are more common. We often talk about dying and how you're coping with increasing disability, but some people, most people are incredibly resilient and just cope. They don't feel unwell. You don't feel unwell with motor neuron disease, you're just coping with the disability it causes, but you're not feeling sick. But then it's a matter of making the most of it. And some people have done some amazing things despite an incredible disability, and continued with travel, or continued with, you know, they have folding wheelchairs they put into cases. There are all sorts of things they get up to get to Bali or elsewhere with incredible disability, which is you know, really interesting how people cope with disability. But again, if depression and withdrawal seems to be a problem, and change in emotional tone, then the offer of trial of antidepressant may be quite helpful. Suicide happens. Again, it doesn't seem to be all that common. I've had one person who's a physical fitness fanatic. When he learned of his diagnosis, he hung himself 2 weeks later because he couldn't see himself, even with minimal disability, progressing to a point of dependency, and he wanted to do something about it while he could. Other people, we've known them to put drugs down their peg tube, for instance, and died. But it doesn't seem to be all that common. Pain in MND is predominantly related to musculoskeletal things caused by weakness and contractures, particularly around the shoulders. Very difficult to keep range of shoulder movement when muscles are wasted and weak around the shoulders, but it should be tempted by the carer as much as possible by daily stretches within limits of pain. Similarly, in the fingers, one has to try and stretch out the fingers to try and prevent contractures if that's beginning to happen. Around the ankles, more difficult again, trying to maintain dorsiflexion range in the foot. And then difficulty turning at night, for instance. So some people we've found just use of simple analgesics or NSAIDs, but in others, Norspan patches have been helpful. And some people claim that marijuana helps. And so people use marijuana, they smoke it, or they use cookies. Merrily Needham's applied to get official access to cannabis for several of her patients who've then used it officially under Medicare, although they have to pay for it themselves. So it's not funded by Medicare,
So even if you qualify for HIV-caused neuropathy pain and you can get official cannabis extracts, you've got to pay for it yourself. It's not paid for by Medicare. Occasionally people seem to have sharp shooting pains or disturbing dysthetic sensations. And there's the odd patient who seems to have had, and it's been documented, they have sensory nerve involvement where Lyrica and pregabalin has been helpful. And I remember one patient I saw who had that. Continence issues, again, bowel and bladder are not directly affected, although if you lose, and in men in particular, they find that their abdomen's poking out more and they used to be very fit and proud of their six-pack, that their six-pack's degenerating into a one-pack. And it's related to the fact that there is denervation going on in the abdominal muscle wall. And so they lose the ability to contract abdominal muscles when evacuating, for instance, and can be a problem. And so the use of appropriate continence aids, urodome drainage of men at night, for instance, and we've had a number of people where they were living independently, but their transfer was challenged or lost. And they could get someone to come in to help shower in the morning, and to go to the toilet, for instance, with opening bowels, but then they had to pass urine through the day and they couldn't transfer. And then they couldn't use a female urinal very well. And with a healthy bladder, thought, well, why not? Let's use a suprapubic catheter. So this girl here, terrific girl, had a great sense of humour. She had an extension to a suprapubic catheter which she called Penny. And it only dropped to me, the penny dropped to me as to why she called it Penny, because I guess it's spending a penny. Get it? So I guess she was spending a penny and she was, extending the sort of Barry Humphries thing about pointing Percy at the porcelain. This is pointing Penny at the porcelain. Now that's her expression, that's not me. So she could either do it herself into a public toilet with a wheelchair sitting there beside a public toilet, or she'd get a friend to help. and we've had a number of people with suprapubic catheters now working with a particular urologist who helps us with this, where it's been critical to allow the person to keep at home and keep mobile, because otherwise they couldn't manage their incontinence, their bladder function. Enhancing communication, so impairment over 80% of patients over time. Not everyone loses the ability to speak before they die, but most people, and some people become anarthric very early in the piece with very good limb function, and they're anarthric. And where alternative augmentative communication devices are very important, and where the advent of iPads where you can write with your finger on the screen and all the rest of it, or change text to speech, have been very helpful. And Manny's going to talk about that afterwards, and he's actually an absolute legend, this guy. He's going to talk to you about that later, and he's just an absolute wizard at helping people with their communication. Even to the point of eye movement, so the sort of thing that Stephen Hawking was using, where reflecting light from eye movement and moving it onto even an iPad sat in front of you, you can begin to formulate words and phrases just by eye movement and reflecting lights onto the screen. Or with a facial muscle twitch or eyebrow twitch is what Stephen Hawking was using at one stage. And formal palliative care service referral. Sometimes even at diagnosis, people will say, well, I want to know what's going to happen to me at the end, and I want to know what sort of palliative care services there are available. Go, oh, well, there's a website, and they say, I want to speak to someone. So, okay. So we can refer occasionally to Sarah Pickstock, Silver Chain, palliative care consultant, or to someone in the hospital about what palliative care services will be available to that person towards the end of their life. And it may be initiated by the patient or by a GP or by us at any time. But we've also made a rule that is generally followed now at most multidisciplinary clinics, that when you go on non-invasive ventilation, you must accept a referral to palliative care, because you might become dependent on it 24 hours a day.
And you might get to a point where you say, I've had enough of this and I want it withdrawn under sedation to die at a time of my choosing, you know. So they have to know that that's a possibility. Now again, it doesn't happen very often, fortunately, but it can do. And so when people are started on NIV at Charles Gardner, they are referred to silver chain palliative care for an introduction and a discussion, and then they're on the books, but they're not kept under review, just in case that situation arises. And we also liaise with MPACs out of, it's MPNCS, I think, from Bethesda, which is a visiting palliative care service across the metropolitan area for people in residential aged care facilities. 9 to 5, Monday to Friday, not weekends, not at night, and have to be invited to participate by the nursing home. But again, very helpful. Silver Chain Community Home Hospice we have a lot to do with, and Silver Chain's been tremendous support for our patients. And we have about 40% of our people dying at home under Silver Chain, which is a very good percentage because it's only about 20% of the general population who actually die at home in Australia. And then inpatient hospice, respite or terminal care at Murdoch, but more particularly at Bethesda. And Bethesda is the only hospital that has public palliative care beds for the Northern Metropolitan Health Service, although the Labor Party, as part of its platform, is promising 25 new palliative care beds at Osborne Park Hospital, which is sorely needed. Glengarry also has some private palliative care beds, as does Hollywood. So Bethesda has a mixture of private and public beds, private at Hollywood, private at Glengarry, and then hopefully, you know, if Labor gets in, then there'll be 25 new beds. And there is a consulting service now at Joondalup. There was no palliative care service at Joondalup until recent years. So palliative care is woefully underfunded. Now, my facts might be wrong in some of that, but that's my understanding of it, and we might debate that later. But anyway, I have some patients who have had enough, even when they are losing autonomy. The main reasons for people wanting to die with motor neurone disease is not pain, it's loss of autonomy, loss of self and dependence on others is a major reason why they say they don't want to go to a nursing home, for instance, and they don't want to put their children in particular under stress of looking after them. And where I had some people who have agreed to go into a hospice and to stop eating and drinking and to die, but with hospice support in terms of symptom relief, with mouth washouts, with crushed ice, with sedation, and where if you do that and you're strict about it, and the main thing is not to take any fluid, then most people will die within 7 to 10 days. Occasionally take a bit longer, and usually a peaceful death, but although the first few days must be very difficult. Voluntary assisted dying legislation has been in Oregon for a long time, since the 1990s. Where you've got to take medication yourself if you qualify, and in Europe countries. And in Victoria it's going to come into being, enacted in June 2019, and we have the legislation in WA being considered at the moment. And that's something that a lot of people with MND are interested in talking about. And it may be that 5 to 10% of them may well take it up if it becomes available. And certainly in USA and Europe, MND is the highest group, that the percentage that takes up the option of voluntary assisted dying. So it will be of interest and hopefully as an option for some people if it comes in here. Now the references, the one that I think you all should, because you're here, because you've got an interest in learning about caring for people with motor neurone disease in all aspects, is this one, So all you do is you Google aspects of care MND Australia and you get access to this free. It's been updated in 2017. It's got all of the stuff that I've talked about but in greater detail. It's got the evidence base and the references behind it. The other summary article was that one in the Medical Journal of Australia in May 2017, which is very good. And then, of course, ALS Untangled is a fun website, and it's a website run by a whole bunch of worldwide experts, medical experts in motor neuron disease, who are looking at all of the crazy things that people get up to. Well, we think, in inverted commas, crazy things they get up to in terms of trying to help themselves with MNDs, and where they have beliefs like, I've got Lyme disease, had a 25-year-old with MND with a PICC line in, getting expensive antibiotics over a period of a year because he was told by a GP that he had Lyme disease. He just happened to have motor neuron disease as well, but the Lyme disease was causing his weakness. And he had a belief that this is what it was, and so did his family, so they paid up for these very expensive antibiotics and all the problems that can come with using powerful antibiotics all the time, until the day he died from motor neuron disease. But he couldn't be disabused, which is fine. I mean, that's his belief. Tried to, but didn't get anywhere. Anyway, so the arguments for Lyme disease, the arguments for all sorts of things, cannabis, but beyond that, all sorts of other beliefs, the Deanna diet, there's a whole bunch of things, are examined in detail, dispassionately, at ALS Untangled. We know that at least 50% of people with MND will take complementary medicines or do other things, which is fine, and we say that's fine, we're happy for you to do that, as long as it's not too expensive. We have had people go to China and elsewhere, for Thailand, for cell transplants and things, stem cell treatments. We generally advise against that because I've never seen anyone who's shown any improvement from any of those particular treatments. There's no proof that any of those things help at this stage. And so we generally try and disabuse people about doing those sort of things. Although some people still go ahead, which is fine, that's their choice to do that. The other references, this is 2010, again, Oxford Care Manual. It's a fantastic book. Everything you ever wanted to know from the British point of view on motor neuron disease. Just a little manual, but it's just very good, just fantastic. And then this one is very helpful. And again, if you're really interested in looking at the detail of care of people with motor neuron disease, the psychosocial aspects, the counselling of children, acceptance of death, fears of death and dying, bowel, bladder, sexual function, potential interventions, etc., cognitive dysfunction, depression and decision making in detail, 2014, third edition of palliative care and amyotrophic lateral sclerosis. So palliative care, we have a palliative approach right from diagnosis, where we're trying to improve people's quality of life in symptom management, but not formal palliative care. So when it says palliative care, this relates to formal palliative care, but the palliative approach to treatment of motor neuron disease. Amyotrophic lateral sclerosis used as a synonym for MND. MND is an umbrella term. We use amyotrophic lateral sclerosis as the most common form of the disease, 85% upper and lower motor neuron, but most people use it as a synonym for motor neuron disease from diagnosis to bereavement. And the authors here are just edited by and authored by a very good team of people. So those are all of the references if you wish to go into this in more detail. Thank you.